This video is for educational purposes only.
The surgical procedure begins with the patient placed in the supine position. An ankle tourniquet has been applied and local anesthetic is often used to augment general anesthesia. The foot is prepped with an alcohol-based solution. The surgical team proceeds to drape the foot in the usual sterile manner using a septic technique. After elevating the limb for 3 minutes, the tourniquet is inflated to 250 millimeters of mercury. The surgeon then marks the appropriate surgical approach. An 8-centimeter longitudinal dorsal incision is made over the first metatarsal and extending distally past metatarsal phalangeal joint. The layer between superficial and deep fascia is identified and separated. This will protect the vascular and nerve bundles. Incision is made through the capsule and periosteum to allow for exposure of the first metatarsal joint. The collaterals are reflected and a dorsal pocket is created for retraction. Care is taken not to resect the dorsal synovial fold. This will prevent long-term stiffness of the MTP joint. A sagittal saw is used to resect the hypertrophic medial eminence. Dissection continues into the first interspace. Soon after, a capsulotomy is performed. The fibula sesamoid is then released, thus completing the McBride procedure. Approach can now be made through the periosteum at the base of the metatarsal and reflected using a sharp periosteal elevator. A guide pin is inserted perpendicular to the weight-bearing surface with the foot loaded. The axis is approximately 1 centimeter from the metatarsal cuneiform joint. The first sagittal saw cut should be in line with the guide pin and essentially parallel with the base of the second metatarsal, while the second cut in a V-shaped wedge should be close to perpendicular to the long axis of the metatarsal and also be angled slightly distal so as to take a greater wedge plantar than dorsal. This will allow the metatarsal to plantar flex as it closes. The axis pin is removed. At this point, the guide pins for cannulated screws can be inserted. Intraoperative fluoroscopy confirms the placement of the guide pins. The pin is measured. A selected size cannulated screw is inserted. The appropriate cannulated drill bit drills over the wire. Once again, the pin is measured. The drill hole is countersunk and the second screw is inserted. Intraoperative fluoroscopy confirms the placement of both screws. Any residual capsule can be resected and then closed using absorbable 2-0 vicryl suture. A 3-0 vicryl suture reapproximates the superficial tissue layers. Skin can be closed with a 3-0 nylon suture. An approach is then made over the fifth metatarsal. The periosteum and capsule is incised and reflected. Again, a dorsal pocket is created so as to preserve the dorsal fold. Holman retractors allow exposure of the hypertrophic eminence. The first plantar cut is parallel to the weight-bearing surface. The dorsal cut is approximately 60 degrees to the plantar cut. The head can be repositioned and then is fixated with either a screw or, in this case, with a percutaneous K-wire. Intraoperative fluoroscopy is often used to confirm fixation. Finally, the step defect is resected. Closure includes absorbable 3/0 suture to reapproximate the capsule. A 3/0 nylon suture is used to close the skin. A betadine-soaked gauze is used to cover the surgical sites, together with 4x4 dressings and a Kerlix bandage. A short leg fiberglass cast is often used when performing any base wedge procedure.
Post-operatively, we did a modified McBride bunionectomy with closing base wedge osteotomy. These are the intraoperative fluoroscopic images that were taken during the procedure. As you can plainly see, the first metatarsal is nearly parallel with the second, and we also did a reverse Austin on the fifth, and that's the reason for this K-wire. Typically, when you make your base wedge osteotomy cuts, one should always remember that the first cut should be parallel as much as possible to the base of the second. The second cut, the distal cut, should be almost perpendicular to the long axis. And the trick to this procedure is, when you make that second cut that's perpendicular to the long axis, try to angle your osteotomy or your cut slightly distal so that when the base wedge closes, it'll also plantar flex the metatarsal.